Neil Bangu. I'm a professor of surgery at the University of Birmingham in the UK. Thank you very much for your time this evening. This is a meeting hosted by the Global Surgery Unit, which is hosted in the University of Birmingham and partners around the world. The meeting today is funded by the University of Birmingham and the British Journal of Surgery. Our main aim here is to launch the new article. This is the pre-launch, which is the Lancet Surgical Health Policy 2025 to 2035 article, Tomorrow's Needs. So our remit in this article was to benchmark what's happened in the last 10 years, and then to try and set an agenda for what the next 10 years might look like as well. So we're going to first hear from Pam Das, who is Senior Executive Editor at the Lancet. Then we're going to have a couple of data presentations and a panel discussion. But the panel discussion will be quite open. I think what we'd like to do is take the temperature of the room and hear from everybody and hear about whether people are optimistic about the immediate 5-10 years or whether people are more pessimistic about that time. And I think we're looking for some honesty in what is going on at the world in the moment. But to start, Pam, could I please invite you to the stage to give some comments, please? You don't have slides, you're just doing comments, aren't you? Please. So Pam, thank you and welcome.
Good evening, everyone, ladies and gentlemen. I see some actually originals of the Lancet Commission. That is John. I don't think we've actually formally met. I've been at the Lancet a very long time, and one of the very first commissions we ever did was Lancet Surgery, and you paved the way for hundreds and thousands more, which has been a complete headache. So thank you for setting the model up. So I'm here on behalf of the Lancet, but I'm also here on behalf of my colleague who the authors of the 10-year follow-up would have been had interacted with, and that's Jesme Baganel, who's our Senior Executive Editor and a surgeon herself, and she can't be here, but I am. So I have the pleasure of speaking on her behalf. So I know the Lancet Global Surgery because I have been at the Lancet 25 years. And as I said, I've seen these commissions come and go, and I've seen the impact they've had and the influence over the years in kind of different political winds and funding climates and things. So it's always good to follow up and keep track on these, really important topics. 10 years ago, the Lancet Commission on Global Surgery delivered a bold and necessary message to the world that surgery is not a luxury, it is essential. Essential to health, essential to dignity, and essential to the promise of universal health coverage. The Commission showed that 5 billion people lacked access to safe, timely, affordable surgical and anaesthesia care. It placed surgery firmly on the global health agenda, not as a specialist service, but as a foundational element of any functional health system, one that saves lives, prevents disability, and protects against impoverishment. Today, we are proud to partner with some of the original commissioners and new colleagues from around the world who've contributed to a forthcoming reflection on the decade since. So first of all, I'd like to thank all of you for your unwavering commitment, energy, and leadership in keeping surgery visible, relevant, and urgent in global health. But the sobering truth is that progress over the last decade has been far too slow. Surgical care remains under-prioritized, underfunded in many national and global strategies for health system strengthening. It's still too often seen as too expensive, too complex, or simply someone else's job. Meanwhile, millions suffer and die each year from treatable surgical conditions. One area that has made remarkable progress is the rise of large-scale, pragmatic surgical trials, including those rooted in low middle-income countries and led by collaborative international networks. We've been really proud to publish many of these in the Lancet, and they stand as proof that equity and excellence in surgical research are not just possible, they are necessary. Today is an opportunity not just to reflect on the challenges of the last 10 years, but to reaffirm our shared responsibility and course a map for the future. As you'll hear in the coming session, we now have better data, stronger partnerships, and growing momentum. What we now need, like I've been saying this in all my sessions, is political will, targeted investment, and a recognition that surgical care is not an optional extra. So thank you, and I hope you have a great session this evening.
So the article itself will hopefully launch in the next few days, maybe the next 7 days or so. So this is what we call the pre-launch. So I'm going to invite Virginia up next to talk about the benchmarking of what the key findings of this series were, this article is.
Thank you. Yeah. Thanks, everyone. I'm Virginia Leda. I'm one of the PhD fellows at the NIHR Global Surgery Unit. And I'm here today to present to you some of the benchmarking highlights that we chose to present to you all as highlights of the Lancet Health Policy. Thanks. So we'll start off with the Lancet Commission on Global Surgery indicator targets. Unfortunately, no LMICs have achieved all the Commission targets. And looking in a little bit more detail, we can see that indicator 1 and 2, so access and workforce, for most low middle income countries are below target. With regards to indicator 3, volume, no low middle income countries unfortunately met this benchmark. Indicator 4, mortality tracking, shows that there is some data out there. However, this is quite sparse and inconsistent. And with regards to finance, so indicators 5 and 6, unfortunately, there are gaps throughout in all countries. Yeah. So focusing a little bit more on surgical volume, there has been a modest increase since the last commission, since the Lancet Commission. However, we still know that the global unmet need is at least of 160 million operations per year. And looking at the graph, we can see that the biggest unmet need is those of adult women, followed by men and children. Focusing a little bit more on mortality, we can see that 3.5 million adults die after surgery each year, which is a huge number. And it's actually a larger number than HIV, malaria, and tuberculosis deaths combined, which is about 2 million per year. We know that most of these deaths happen after emergency surgery and more likely to happen in countries with low HDI. We also found that in the last 10 years, the surgery is actually a driver of antimicrobial resistance. This is because SSI is one of the commonest post-operative complications, with rates that have gone up to 50%. And we know that patients in low-income countries are administered antibiotics both preoperatively and postoperatively. But one of our studies, Falcon, shows that when we have swabs available, 96% of those actually demonstrate antimicrobial resistance. Focusing a little bit more on finance for this next point, we can see that half of the patients in low-income countries pay for surgery out of pocket. We can see that in higher income countries, healthcare surgery is publicly funded or funded by insurance, but the out-of-pocket expenditure goes up in low-income countries. However, we also know that there is a lack of up-to-date comprehensive data on catastrophic expenditure. And looking at this data, we might think, oh, surgery is very, very expensive. But actually, looking at unlocking the surgical prosperity, so if we're actually to improve surgical services in low middle income countries, we could increase our returns. So scaling up breast, stomach, colon, and rectal cancer could return over $80 billion each year, showing that it is really important scaling up cancer surgery worldwide. What did we learn over the last 10 years? Well, definitely COVID taught us a lot. And COVID-19 pandemic had a catastrophic impact on elective surgery, with 28 million estimated elective operations cancelled only in the first 12 weeks of lockdown. However, on a positive note, this was also an opportunity that has made us realize that we can get to high quality, strong evidence, which we were able to obtain through collaborative efforts, and that was able to change measures in operating theaters and hospitals worldwide, reducing post-operative mortality of patients. Another lesson that COVID taught us is that hospitals need to be better prepared. And our unit developed the Surgical Preparedness Index, or SPI, that was developed to assess the preparedness of a hospital. And we were able to assess the preparedness of matched hospitals over the course of 3 years. However, this showed marginal progress. And linked to preparedness, we know that energy security is a massive problem worldwide and it's at a critical point. We know that 40% of hospitals overall and 90% in low-income countries are affected by at least one power outage a month. And on average, an affected LMIC hospital can experience power outages 6 to 9 times a month, days a month. And this has not only a massive impact on surgical system and surgical delivery, but also on the delivery of safe childbirth and vaccines. So this is the highlights, and I'm going to leave Dimitri to discuss our future priorities. Thank you.
Yeah, well, thank you very much. So following on from Virginia, we're just going to have a look at what our recommendations coming out of this review were. So next slide, please. So surgery is more important than ever to global health. We know that it has a key role to play in achieving the Sustainable Development Goals, particularly SDGs 3 around work, 8 around returning people back to work and productivity, 5 around gender equality. But actually, it has an increasing role because of all the uncertainty and shocks that are happening in the world at the moment. Examples are climate and extreme weather events, where we're having to look after trauma patients, future pandemics, other events at this week. You will have heard about the role of surgery in underpinning the COVID-19 response. And I think most people involved in pandemic preparedness believe that further pandemics in the next 10 years are very likely. Energy security, as Virginia has just described, is a huge issue, and hospitals could be a vanguard in increasing energy security in their communities. And also, sadly, over the last few years, increasing armed conflict, terrorism, and other hybrid forms of conflict, such as cyber attacks, occurring, which will disrupt healthcare. So surgery has a key role to supporting response, preparedness, and reducing the impact of these events. Next slide, please. More broadly, surgery can be a vanguard to strengthen whole hospital care. So we think we should be repositioning surgery rather than talking about individual procedures and individual patient groups, repositioning it as a foundational component of well-integrated health systems. So the diagram here that one of our colleagues, James Glasby, made demonstrates how investing in surgical infrastructure, such as radiology, pathology, blood products, medical gases, which are central to delivery of surgical care, actually can strengthen through vertical integration other patient pathways throughout the hospital. So it can be a smart investment to invest in surgery, because that will strengthen the care of a whole set of different patients going through the hospital who will benefit from having a CT scanner, benefit from stronger drug supply chains and so forth. So by vertically integrating surgery across the hospital, it can become this vanguard that boosts care. Next slide, please. Research clearly is critical to the further development of global surgery. And it's really important that as we head into these uncertain times when funding is tighter, that we still prioritize some funding for global surgical research platforms that can maintain the visibility and progress of global surgery. I think we've come a long way over the last 10 years, and it would be a shame to lose some of that increased awareness and visibility of surgery if we were less able to capture what goes on around the world. We did a Delphi, as part of this exercise, we did a Delphi study to try to prioritize some of the key surgical research priorities, and those are in the blue box. As you can imagine, many of them are around reducing postoperative mortality, addressing surgical site infections, but we also need to do more whole system research. How do we integrate surgery across primary, secondary, tertiary care? How do we work with multidisciplinary colleagues to prevent trauma and surgical disease? How do we work with health system planners to scale up the surgical workforce? So I think definitely a call for more multidisciplinary, multi-system research. Next slide, please. So the path ahead, as we just said, we think it's really important to continue to invest in data infrastructure to ensure that we don't drop down the agenda, particularly as the higher profile areas in global health come under increasing pressure. That is definitely a risk, I think, for surgery. So we need to maintain that visibility. We need to focus on prevention and early treatment because that will allow us to focus our surgical capacity on those patients who are at the point in their disease when they will benefit the most and gain the most economic benefits from that. And I think we need to communicate more smartly sometimes with governments and other policymakers and funders so that they understand the economic benefits of investment in surgery. I think that is something that has to be a constant refrain that, of course, this will cost you money, but in the long term, this is a key investment to see the development of your countries going forwards. And that's as true in high-income countries as it is in low-middle-income countries. In the UK, we have a huge problem at the moment with increasing people out of work for health reasons, and some of that will be because of surgically amenable conditions that have progressed. Next slide, please. So to summarize, the key messages from this article are that unmet need, unfortunately, continues to rise rather than fall. That's partly driven by population growth, aging population worldwide. As people get older, they need more surgery. And so the need for surgery increases rapidly and will continue to increase over the next few decades. Postoperative deaths exceed other major global disease burdens, and therefore quality and safety of surgical care needs to be a central pillar on the global health agenda if we want to maximize the health of our populations. Vertical integration is key, and surgery can support health systems beyond the operating theatre by strengthening other aspects of hospital care, such as diagnostics, intensive care, and we've talked about that. The surgical prosperity dividend, I think this is a key point we need to be communicating, as we say, that by investing in surgery, we can unlock that boost in productivity. We can get our populations to be getting into work, generating more tax income to fund these public services. And finally, the preparedness is an essential but lagging component at present. I think if we had another pandemic, very few health systems are significantly more prepared than they were in 2020. And it's important that we don't forget those lessons. I work in public health, and if I'm honest, I think even in public health, we're forgetting many of those lessons. So it's really important that we work as quickly as possible to learn from that experience and make sure we're more prepared as we go into this more uncertain world. So these are some of the messages we've selected out to present from the paper. There are many other points that we haven't covered. So look forward to hopefully all of you having an opportunity to read the full paper in the next few days. Thank you very much.
Could I ask the panel to come up, please, and take your seats? So all of you, if you could come up and take the seats on stage, please, I'd be very grateful. So this was not a full-blown commission. This was a health policy article. So it's one single long article with a supplement with quite a tight remit to benchmark and predict for the future. So could we do some introductions, please? Drew, I'm going to start at this end. Quick introduction and we'll run down the table. And Rosella, you need to do a couple of extra words on emergency, please, at the end. So Drew, you first. Your mic should be...
Hi, I'm Dhruv Ghosh. I lead the global surgery unit in India. I work out of Northern India with a network of about 130 hospitals across the country.
John Mira from Boston. I'm a member of the program Global Surgery and Social Change.
I'm Stephen Tabri from Ghana. I'm professor of surgery and a dean of UDS Medical School. And then I'm a co-director of NHR GSU. Thank you.
Adesoji Ademwewa. I lead the NIHR Global Surgery Unit in Nigeria, and I'm a professor of pediatric surgery at the University of Lagos.
Hi, I'm Sohini Chakraborty. I am the Intellectual Property Commercialization and Impact Lead for Biomedical Research Center and the College for Medicine and Health at the University of Birmingham. Thank you.
Good evening, ladies and gentlemen. I'm Rossella Miccio, and as Anil was saying, I'm the president of an Italian NGO, an Italian-based NGO that's called Emergency. And we started our activity 31 years ago, mainly with hospitals for war wounded. And since then, we have been providing mainly surgical assistance in 20 countries. So far, treating over 13 million people, and we have been happy to join our efforts with the Birmingham group to provide some data about the results of our work in the past 10 years.
Okay, microphones on, everyone. So we're going to do some comments, but there are a couple of roaming mics, are there? They're not roaming yet. They will be in a moment. And so we're really keen to hear people's experiences. I'm particularly keen to hear about the financing situation around the world. I don't think we should hide from the funding cliffs that some of us are facing, and I'll talk about our own. But John, can I start with you, just because you just your reflections on you did the commission. This is our health policy article, and we tried to do some benchmarking about what's happened. But what are your sort of personal and professional reflections on the last 10 years in global surgery?
Well, that's not a terribly broad question. It shouldn't take me long to cover that. I guess what I would say is I don't want anyone to be comfortable or complacent. So I want you all to have a sense of urgency. But on the other hand, I would say don't be frustrated. I hear comments all the time that not enough progress has been made and it's too slow, and all of that's true. But I can remember back in 2010, 11, 12, I remember Robert Riviello, who's now the director of PGSSC, he was contemplating, should he get involved in global surgery or not, because it wasn't really a thing, it wasn't, the university didn't really recognize it, the dean, Harvard Med School didn't really recognize it. And so when I think back on what all of you have done to change the culture of the concept of global surgery, and I will tell you, it's exactly what Paul Farmer wanted. He talked about this a lot. He wanted there to be a culture around global surgery and anesthesia that validated the importance of this and validated the importance of what all of you have done. And then it wasn't just, you know, a hobby, and it wasn't just something that you did on the side, that it became part of you and part of your career. So I actually think there's been tremendous change in the last decade. And as I said, yes, it's been too slow, but because all of you have not given up, I've really seen, you know, with the arc of time, a tremendous amount of change.
Yeah, thank you. And I think one of the outcomes of the original commission is the increase in research networks around the world that took place, which is I think that's a real positive. And Stephen, can I ask you what the impact has been on the Ghana networks around the research that has taken place?
Okay, thank you very much. I think we've done extremely well, especially with the district hospitals. Before we started, everything was about the teaching hospitals. But then where the majority of patients are living are in the district hospitals. Sometimes before then, people have to travel about more than 100 kilometers to go and get, for example, simple hernia repair. So we said, no, we have to go to the district and then build capacity in terms of research, and also provide skills and training at the district hospitals to provide basic surgical care for the population, majority of populations living in the district, in the communities. And one of the things we've done is that most of the clinical trials we've done, even though we are involving the teaching hospitals, we also don't leave the district hospitals out. And then in some of our activities, we talk to community members to find out what are their needs. And for example, one of the things we were informed about the burden, surgical burden in the districts, in the communities, inguinal hernia, which is a major problem and it's common surgery apart from CS in Ghana. So then we design trials, we design work. We started with a whole teaching hospital where it wasn't a randomized control trial. We train non-surgeon physicians in a short term to operate hernia. They hadn't received any formal training, but we were able, as a team, able to give them short-term training to be able to repair safe inguinal hernias. We went further to find out from the communities, what do they think? Do they prefer a surgeon or they prefer someone who has been trained, a doctor, to repair the hernias? And then they agree that the findings from one of the hospitals is what they expect. They don't want to travel far away to go and get their hernias repaired. So apart from involving the district hospitals, in most of the things we do, we put patients who are living with a condition or has gone through surgery, and then we use the experience to design most of the trials we do. Thank you.
Thank you very much. And a question for Drew. Off the top of your head, how many new surgical researchers do you think have been trained across India over the last 8 years?
Thousands. Yeah, we started in India with, when we started GSU in India in 2018 and 19 with 5 hospitals, and most of them in Northern India, except for a hospital in South India. We now work around 130 hospitals, and like Stephen said, they are not just teaching hospitals in big cities like Delhi and Bombay, but they are rural hospitals where DHL or FedEx doesn't reach. And we sometimes have to take interventions ourselves. Sometimes you have to travel on train by a couple of days to reach these hospitals. There are researchers and research infrastructure. What we tried to do through GSU was to realize that many of these hospitals, especially district hospitals and rural hospitals, are single surgeon hospitals. They don't have the time of the day to do research. There is a huge amount of data that is there. That's real data. Most of the literature that was coming, surgical literature that was coming out of India, was coming out of hospitals in Delhi, but that's not real India. Even now, 60% of India stays in their rural areas, in smaller districts. What we try to get there is locally train a research associate, or more importantly, a research nurse. I think one of the big victories in India was to get nurses and surgical nurses involved in surgical research. I firmly believe that if you want to change surgical outcomes on the ground, you have to have the nurses involved, otherwise nothing's going to change. We got anesthetists. In countries like ours, there's a hierarchy. There's a sort of a caste system. The surgeon is the really high caste person. We've tried to change that over the last 5-6 years, where you develop surgical teams. Surgery was never a problem in India. There is huge amount of surgical expertise, both in big cities and small cities. The problem was also to set in systems that will make surgery safe for patients. While we were doing surgery, we were not doing safe surgery. And that's what we've tried to change with GSU, is to train our researchers, train our surgeons, train our surgical teams, our anesthetists and nurses on how to do safe surgery. Simple thing like the WHO surgical safety checklist, almost 0% compliance before GSU started. And today, even once the trial is over, there is 60 to 70% compliance in many of our smaller hospitals, better compliance in our rural hospitals and district hospitals than in our teaching hospitals, actually. So these are things that have changed over the years, and I'm sure 130 hospitals, lots of surgical researchers, more importantly, lots of surgical nurse researchers, lots of anesthesia researchers, a lot of research associates, and a lot of research nurses. Yeah.
Thank you, Dhruv. I'm going to flip now to funding and financing, which I don't think we can avoid. I'm very keen to hear from anyone in the audience who's got anything to say on the funding cliffs that we might be facing. If anyone's facing those, or anyone has any intelligence to give us on this. I think, as a NIHR, so that's the UK's health funder, we're all facing funding pauses on our research going forward into next year, which is a worry. And that's due to the effects of changes from Trump's America, but that have flown throughout the ecosystem of global surgery and the reset. So we've tried to get this health policy article. We started it well before the new Trump administration was in place, actually. And so we've tried to now get it out with the changes that are happening. And as you'll see when it's published, hopefully most of it will remain relevant to the narrative. And Pam was saying to me before we started that one of the tricks with these is to keep the same message going, keep repeating the same message. And sometimes you only have to say it to the right person once for it to have a big effect. So she says she really doesn't want people to give up hope. But in terms of funding and financing, Sergi, can I come to you? And I'm sorry if I ask anyone unfair questions now, but how are sort of Nigerian hospitals doing with their funding and financing problems? And just to be unfair to myself as well, my hospital in the NHS, we're facing a shortfall of £143 million this year, and we've been told to close that, so we probably won't close that gap this year.
Yeah, thank you very much, Anil. As you'll expect, Nigeria is a low middle income country and with challenges with respect to funding. And as a matter of fact, even the Abuja Accord, which was to bind African nations to devote about 15% to health, has never been met by budgetary allocation from the country. So you can imagine what the challenges are with respect to our hospitals. But there has been different models that different hospitals have adopted. For example, in my hospital, there has been more of public-private partnership to try and attract industry to address many of the shortages. So one major issue in our hospital is the issue of energy crisis, as you will expect. And what our hospital initially did was to get an independent power project that is gas-powered. However, with the economic climate, with the dollar going up, that was not sustainable. All the IGR of the hospital was going to support power. So what the current leadership has done is to get private partners to supply solar And a good number of the critical area of the hospital, like theater, like some of the wards, like radiology, are being powered by solar at the moment, and they still continue to do that. Another thing they've done is we have the National Sovereign Wealth Fund, which donated about $10 million to empower the hospital to have radiotherapy. And our hospital has one of the best in West African sub-region at the moment. And that is also from this partnership. So there are ways that people are trying to address it, but I will say that it only scratches the surface. There is still need for the government will. There is need for the government to be committed to improve funding for health. Thank you.
Thank you, Soji. I'm gonna pick on people now. So Richard Sullivan, I pointed and I said you next, and you nodded, and I've got a man behind you as well. So Richard, could you introduce yourself and just what if you're willing to share, just give us some thoughts on what the wider landscape of funding is at the moment.
Okay, thanks very much. I'm Richard Sullivan. I pleasure working with John and others on the first commission and with Anil as well. So, and I think Anil's asked me because I sit on the World Bank's financing group at the moment, specifically leading the cancer program. I guess where we're sitting at the moment, and this is from discussions we've been having with the senior hierarchy of WHO, is it's going to be chaos for the next 12 months because simultaneously everybody and everything is being cut. So just to give you some idea of the figures we're talking about, just simply in overseas development assistance here from high-income countries, compared to 23, about 10 to 12 billion is going to be wiped off this year alone. And that figure is probably going to rise between 15 and 20 billion, we think, as defense expenditure increases. The tariff impact is going to be huge as well, anywhere between 0.5 and 6% of GDP. Places like Lesotho, for example, they're going to lose 6% of their GDP, even the tariffs as they stand now. So these are massive seismic changes, but it's very variable, the impact. I mean, learning colleague from Nigeria there, I think where you've got domestic resource mobilization, some countries are going to weather the storms far better than others. But right now at the moment, all of this, we're looking at between about 56 and 72 countries which are getting red listed because their global health expenditure on domestic health, public expenditure, their out-of-pocket expenditure, their reliance on external funding is so high, any form of cut is going to be catastrophic for what we consider to be basic 101 services. So you'll all be aware around the world now, for example, TV services, HIV services are just stopping in countries. But the problem is we can't predict at the moment what's going to happen because everybody is cutting and altering their strategies without consideration for anybody else. And to be blunt with you, and I'm sorry if I don't know whether there's WHOs in this room, this is true of even WHO, okay? So 20 to 30% of staff are going to be lost. Everyone's seen the new organogram, so everything's been collapsed together. They've had to do this without any forward strategy. So in a sense, it's cut first, strategize later. So right now, at the moment, it's kind of, you know, that dreadful thing of in the Navy of hold fast. You've just got to hang on for dear life and get money from wherever you can. But I think, you know, there are some countries for which the impact is going to be really, really terrible. Others that will weather the storm better. But between now and the end of the year, no one has a clue. And I speak from another insider within the British government as well. If we don't know, nobody else knows. And we don't really know, again, for the American administration, what they're going to do next. But one silver lining, I want to say it's ended with something positive. The Chinese premier turned up here at WHO and basically offered everything. Surgical supplies, medicine support, in other words, plugging the development gap. And this will include surgery, medicines, you name it. Now, the focus is going to be sub-Saharan Africa. We don't know what that's going to mean yet. And obviously that cuts two ways, and we don't know how the Americans will react to this. But nevertheless, what it does mean is a massive recommitment and expanded commitment from a growing superpower in the global health and development space. So does that answer your question?
Yeah, thank you. Thank you for, well done. Thank you for, hey, look, and thank you for an honest appraisal. I think it's better that there's no point sitting here telling each other, we'll just go to gates, we'll just go to gates. We need an honest assessment of what's going to happen. And why do we need that? So that we can strategize for the next 5 years. So we make sure that we'll all survive for the next 5 years. And in 5 years, we see what is there and we have our message ready to go then. It ties into, so I'll come to Rosella next with a question, but it does tie into one of our points from the Lancet article. So the first commission said the unmet need for surgery was around 143 million. We've said it's grown a bit to 160 million as an estimate. But I think it's worth reflecting that all the activity that has taken place has stopped that figure going even higher. And that is, so I see that as a success. I thought it was going to be within the confines of the estimations, cataclysmically higher. So I think it's quite impressive that has not disastrously gone up. So Rosetta, I think one of the things we pick out in the article is the importance of the NGOs in that figure who have gone to provide frontline care, who have provided surgery, who have plugged gaps where others have been able to. So, congratulations on that over the last 10 years. But looking forward, how do you feel about the immediate future and the changes, and how's Emergency feeling about it?
After what I heard here, not exactly fantastic. No, I have to say that being an NGO that has been mainly working in the surgical field, we have always faced challenges in terms of funding and in terms of, let's say, particularly at international level with the major international institutions and so on, much less in the dialogue with the local ministries of health and authorities, because for them, the needs are very clear. Therefore, in most of the countries where we worked, I have to say that we have found pretty good cooperation and understanding and tried to join efforts in supporting the hospitals, the projects that we were running, also because they were providing services, but also training building capacity at local level. And this, I think, has been one of the key activities that we have carried out over the last few years that have directly involved governments. Of course, one of the biggest tragedy over the last particularly 2-3 years is the also increase of conflicts and wars that are not only having direct impact in the countries where these wars are taking places, but globally, prices are increasing, skyrocketing. So whatever was costing $1 million 3 years ago, now it's the price is 3 times. So to run the same kind of activities of 3 years ago, we have to invest 3 times the budget. And this is a huge challenge for NGOs, but I think that it's a huge challenge for the world itself. So it's, I think that this kind of analysis and data are very important, as it was the Lancet Commission 10 years ago. It changed completely the context. It was much easier for us to go and explain. But now, when I saw the data about like the positive return on the investment, if we invest in cancer surgery, these are figures that should, I hope, help everybody to understand that it's not a choice. It's an inevitable decision that we have to take to support this kind of activities. And it has to be at global level. Also, from our point of view, because it's a basic human right. So if we really believe that what is written in the Universal Declaration of Human Rights, that we are born free and equal in dignity and rights, I don't see why the right of me being born in Italy should be different from the one of a person born in Afghanistan or in Sudan. So these are things that should be joint, let's say, joint values on which we shall build to strengthen the services, the surgical services, in particular in low and middle income countries. And
just, I think values are, and we've spoken about this, values are so important to us all. the first value, for example, should be not going to war. I think you said that to me. Preventing war should be the first value. And then if it can't, we'll be prepared for it. And I just, in this world that's changing so much, maintaining our values like that is important.
But what we have seen in countries like Sudan, for example, where we have been working for the past 21 years, till 2023, we had the Ministry of Health that was co-financing a surgical center for cardiac surgery, so not something cheap, that was providing services free of charge to the population of 30 African countries and doing training 50%. Since the war started, of course, all the budget went to the war. No more money was left for healthcare, and not just that hospital, but all the other hospitals. So these are things that we should also advocate for as a global health community, I think.
Thank you. Just a slight change in tact. I think it is very useful to understand what governments are looking at the moment. I'm going to come to Sahini next, and to understand where governments want to invest. And I think going forward, that's probably going to become more important than it was 10 years ago in terms of funding streams. So just as a slight difference, UK funding streams at the moment, Sahini, you've seen some movement with what they would call sort of innovation and SMEs and things like that. Do you think the UK government's looking more or less into that field?
Good question. I'm not sure I can speak on behalf of the UK government. But what my analysis says is that UK government at the moment has definitely paused ODA funding, that's for sure. But even internal research funding, UK government is actually scoping out how much of that other kind of internal research funding should stay, where should it be prioritized, how much should go where, etc. So funding overall has had an impact. Going to SMEs, so far, organizations like Innovate UK, which work very closely with SMEs and other industries, along with universities, have also seen budget cuts. And some of the calls that they had given out, they have actually retracted on them. But it is very unclear at the moment, and I think we'll have to wait and watch for the next 6 months, while a lot of scoping is done right now by not just government agencies, but also industry experts, etc., to see where funding will flow. And one thing, I'm sorry to say this, but one thing Trump is very, very good at is that he doesn't always do what he says. So maybe he will change his mind and he will see the importance of carrying on providing funding to other things except defense.
If there are any questions or comments from the floor, now's a good time. But yes, please.
Yes, I might take a little bit of a contrarian point of view and taking deference to our colleagues from Sub-Saharan Africa, as you described, for surgery, training people, rather than being fully trained surgeons to do basic procedures. One statistic from a study that was done over a decade ago in the EU, the average number of cases, operations done by a neurosurgeon in the UK is 300. In Greece, it's 56. There's such a variation, and when I get data from LMICs, many of my neurosurgery colleagues are not very productive. And we kind of lost that. We need more money, we say, but maybe we could be more efficient. I mean, doing 56 cases versus 300, that's a huge difference. And so I wonder how much of this deficit we have now in funding, we might make up just by focusing a bit more on being proficient, finding out why people are not able to be proficient, effective, efficient at a given hospital. It's going to be different in different places, but it seems like we need more money, but maybe we got to look inside and say, how can we do this more efficiently?
Stephen, do you want to comment on that? So proficiency, perhaps, and I know it's a global question, isn't it? But in the context of what you're talking about, the district hospitals and what's happening there.
So I think what we've been able to achieve before, it was expatriates coming to Ghana, gather people 1 week and operate their hernias. And we realized that if we continue to do that, there was a modeling study that was done by the group, and we realized that continue doing that, we're going to have a backlog of about 10 million inguinal hernias. So we took it upon ourselves as a group of surgeons, we formed Ghana Hernia Society with a little support. We are now training, before it was only surgeons, people performing the inguinal hernia surgeries did not have official training. So they do what they've seen. There's no standardization. So we came in and said, well, let's try to solve the problem. And then we are now taking upon ourselves to operate on the inguinal hernias, not in the cities, not in the hospitals, but going to the district and then also train the middle level, what is known as non-surgeon physicians. That means the person completed medical school, he has done mandatory 2 years of house job and is now a medical officer. So the target is to train them to offer inguinal hernia services rather than wait for them to strangulate, then major surgery, major complications, outcome is terrible. People are not able to go to their normal state after the inguinal hernia repair. I mean, if you get to the complication of strangulation, obstruction, and etc. So that is what we are doing internally by sponsoring ourselves, collaborating with the Ghana Health Service, and said, giving us the authority to go to the hospitals. At least the basic thing we need is the accommodation, how we can stay for 5 days to train. And that's what we are trying to solve the problems internally. Thank you.
Thank you. So Soji next, and then Dhruv, and then we'll go back to the floor.
Yeah, thank you very much for that comment. The other thing that I think is essential is the fact that access is a major issue. So where patients have disease, but they can't access surgery, it will also impact on the figures. And I can tell you a study that we did, we estimated that for children, we'll have 3 million with congenital anomalies that do not have access to surgery in Nigeria. And we just completed another study that shows from the Lancet Commission about catastrophic health expenditure that any child that goes into surgery, 3 in 5 families will go into catastrophic expenditure. So that again is something that reflects on those numbers. It's not just the fact that there are no surgeons. Sometimes they are there, the facility is there, but there is limited access because there is no health insurance. Whereas in other places where there is health insurance, somebody is ill, you just go on the list and you get your surgery done. So that may also be responsible. Thanks.
Thank you. Dhruv?
Yeah, that's a great question. And what we are looking at is efficiency of a surgeon. In countries like ours, the question is whether we have over-specialized. The general surgeon is becoming a dying breed, but the specialist doesn't go to where the people are. The specialist stays in big cities because various reasons, economic, children, families, etc. It's the general surgeon who is there in the field, but the general surgeon doesn't know how to put in a burr hole or do a cesarean section or do a stoma in a neonate right now. I think over the years, especially in countries like mine, we have over-specialized, and now we have a small group of general surgeons who are able to do everything. And there is lack of people now in our district hospitals and rural hospitals who can do these emergency procedures because everybody's sitting in the cities. They don't have enough work in the cities, neurosurgeon, pediatric urologist, but they don't want to go into the rural hospitals. And so that builds into lack of access again.
Thank you very much. I'm going to move on to, someone had a microphone over here? Yes, please.
Okay. Thank you for the opportunity. My name is Perpetual Freyampofo. I'm from Ghana, and I'm a nurse. It's interesting what you are sharing and the data that you have shared. But of course, just like Doc was saying, the issue about funding, not funding for general projects, but funding for surgery, it's also very difficult for patients and their families. And I just wanted to understand from the work that you are doing, whether you have made a strong case for countries in which you are running these projects to really mobilize internal resources to support. Because just like we have heard, even for West African countries sticking to the Abuja Declaration of allocating just 15% of the national budget to health. It's not really happening. But the impact of surgery, as we know, for families are difficult, and people won't hesitate in my part of the world, will not hesitate to resort to traditional medicine and other alternative kind of treatments just because they cannot afford surgery. But at the same time, I want to know whether you have partnerships with pharmaceutical companies and how they also come in to support, and whether you are also involved in some collaborative surgeries where you repair and reconstruct at the same time in terms of one surgery while the patient is on the table.
Thank you very much. Thank you. And I agree with those points. John, I'm going to come to you for another impossible question. You comment on that. And the other thing I just wanted to comment on, if you can, is just a quick 10-year summary on the national surgical plans.
Okay, I'll get to that next, but you made me think of something adding to what Richard said. You brought up mobilization of internal resources. And you think about all the things that Richard brought up and all the Trump chaos that's going on right now. Does the tactic that you use in your own country differ now because of what's happening? Or do we go with the same arguments? Is it the same thing? Because I guess my Uber strategy question is, does what's happening in the world right now change our strategic approach? You know, when you look at the recommendations from the Lancet Commission, when you look at the recommendations from here, are there things that bubble to the top because of the chaos we're in? Or as Richard said, do we just have to batten down the hatches, buckle in and ride it out? And I don't know the answer to that, but your two comments made me wonder from kind of a grand strategy perspective. And there may be an answer that depends country by country. And then I guess the next question would be, as a group here, as a global surgery community, does our strategic approach change because of all this chaos? And again, I don't have an easy answer for you, but I'm thinking, what do we need to do differently? Because probably more of the same is not really going to help. But I wish I had a better answer for you.
And it's maybe if anyone wants to comment, they can, but otherwise, yeah, we got two comments there. Yes, please. And the lady behind you. Right. Good question. They're really insightful and thoughtful.
So my name is Richard. I'm the General Secretary for Ghana Medical Association, and I'm part of the Ghana delegation to the World Health Assembly. A few comments on some issues. I noticed that even in the presentation, there wasn't so much emphasis on prevention. And I think the less we prevent, the more the burden, and we have to play catch up. I think it goes into the analogy of people dropping into the river upstream, and we as surgeons being downstream and trying to pull them out one by one. And we probably will tire out at a point and may not be able to pull them all out. And thankfully, there are tools to prevent quite a number of the surgical conditions, like some of these vaccinations, for example, for HPV vaccinations for the female cancers, and then also the need to screen and catch them early. There seems not much emphasis on this. And probably that may be one of the more efficient ways to begin to look at cutting down the burden and educating people. And I notice also that we probably are also not bringing on board communities as strongly as they should. Because in some of the communities in Ghana, Prof will tell you that where communities are made to understand the reasons and why they may not have certain things, they are able to mobilize. Some have built the whole theater complexes for their hospitals and done other things that are more beneficial. I also think we should pay some attention to innovation and local production, because in Ghana, for example, a lot of the surgical costs come from the cost of the inputs. For example, cost of importing implants, the gloves, the other things, the surgical drains. If we could manufacture some of these things in country, the cost goes down big time for us. And I think we should encourage universities to begin to research into these things and then support them to produce these things. Thank you.
Yeah, and thank you very much. If the microphone can go behind you for the last question. But to comment on that, I agree. And what we're going to do with these slides is we're going to make them very publicly available, because people have said to us they want to go and present them locally and regionally. So we'll add in your points, please. I think they're very important, prevention and community. We cover some of them in the article. We didn't have time for them. And then people can choose what they present locally. But it's a very, very intelligent point. Thank you.
Hi, I'm Katayoun Madani. I'm with Baylor Center for Global Surgery and the Association of Academic Global Surgery. Thank you for the wonderful panel. I think I'm from America, so I go through every hourly sometimes daily, of the ebb and flow of despair and not seeing opportunity like everyone else. So it's not that I have a solution or an answer. However, when I took a step back and look at what we are looking at and worrying about these budget cuts and so on, the reality is, yes, the well is poisoned. However, we were never invited to this well. We spent about 5 years focusing on USAID, trying to advocate, put the language in. I personally went up and down that hill with many of you who are here in this room. Never got a penny. So we did not have funding. So to me, the opportunity right now is we have been neglected before because the infectious diseases got a priority. They are going to go for other funding pots that may exist, and we need to figure out how do we now become a priority. I think your article has a beautiful, beautiful set of data, especially that value of 80 billion added, that will get attention. I think tapping to your comment, we need to build community. Your history here with collection of data from around the globe shows that that is successful in research. We individually may not have a lot of resources, but together we have a lot that we can combine and bring together and build on that so that we can build our community and come out of this stronger.
Thank you very much.
Before we get to the next speaker, your comment reminded me of a saying. You were talking about putting so much effort into USAID. The only time to put all your eggs in one basket is at Easter, and we we did that. We picked a few things. So maybe part of the strategy is don't put all of our eggs in one basket. And Richard brought up China. So what's their role now? Will they fund surgery? I don't know. No, they won't. We have someone who says absolutely not. Okay.
Yeah, I think, John, I mean, they make an important point. We've done a lot of research. How much of that research have we actually converted to implementation on the ground? That is something that we probably need to do now. It fits in with what everybody else is saying in terms of actual implementation of whatever data we have. That's one. Traditionally, for research, we have looked at the Western economies. The world has changed. I think we need to start looking east, even for research. The emerging economies, which are going to be number 1, 2, 3 in the next 5 to 10 years, are the economies we should be working with now, because I think Western funding for research is going to dwindle down, whatever administration comes. And it is towards the east that we will have to look in the near future in terms of both research and implementation. But to get these economies to work with us, we have to show that we can implement whatever we have researched, and that is doable. And if we don't do that, nobody's going to fund us.
I am sad that I have to agree with you, but I think we can no longer depend on the US as a major funder.
We'll go to the first of this evening's discussant summary. So the role of this is a short summary of what we've said and some other reflections. So Professor Dion Morton, please.
How do you do? What a great panel discussion. What a vibrant audience. But the crux of it is that we are dealing with a huge disruption to global health funding. And the real question for us is, as the lady was just alluding to, can we keep surgery on the global health agenda, or will it be overrun by the mainstream infectious diseases? And I think that is our responsibility. And I think the work that's being done by the global network of surgeons and professional surgical staff is central to that. We've actually heard data today from allied health professionals, nurses, anaesthetists, and surgeons that have been collected from 120 countries by some 40,000 clinical staff. That is real data that can change minds and influence governments. And that is the data that's been used in the policy documents been put together through the Global Surgery Unit, led by, of course, Dimitri and Anil. What do we take away from this in terms of solutions? Because we're too old for just describing the problems, and we have started to look at that. I think that the data that's being used is data that is snapshot data, audit data, not registry data. We can keep collecting this data. We have almost 400,000 patients' data collected over recent years, and it can be up to date and it can be informative. And that data can actually tell us where the gaps are and where the improvements are made. The community of surgical staff can identify the need and prioritize the interventions that we can then test through the global networks and actually deliver change measured in improved patient outcomes, measured in improved patient throughput in hospitals, as you allude to. These things can be measured in real time, but and we can do this now. I don't believe we can collect registry data now, but we can provide data-driven objectives, which we can measure in terms of their delivery. I'll just finish by saying the final point is that we need these integrated funding streams to look at health systems, whole health system strengthening. Investment in surgery will do that. It will strengthen the vertical systems in the hospital and the horizontal systems of care pathways, both emergency and elective. And that strengthening of pathways will also address the question of prevention, because it will prevent late surgery, it will prevent complications, and it will allow early, safe surgery to be delivered. And I will just steal Dimitri's punchline, which I think is a great one, which is by doing this, we will unlock a prosperity dividend, which is substantial and will benefit the world. So a great piece of work, really enjoyed it. Thank you.
Whilst the next speaker's coming up, and we're going to change panel, I'd like to thank this panel very much for your comments. Thank you very much.
Hello, good evening, and thank you very much for coming to the session. My name is Theophilus Teddy Kojo Anyomi. I'm a clinical research fellow with the NIHR Global Surgery Unit in Birmingham. I'm excited to share some insights from our ongoing cohort study, Alligator, which looks at outcomes of appendectomy across the world and how this can improve emergency care systems around the world. Next slide, please. Appendectomy is one of the most common emergency operations worldwide. It exists in every health system, in every country, and makes it an ideal lens to look through, study, and how to access decision-making and outcomes in emergency care. It has been prioritized by our frontline teams. Next slide, please. Alligator is a prospective cohort study on patients undergoing appendectomy for appendicitis. All ages are inclusive. All hospitals providing appendectomy are eligible to participate, as long as they have necessary approvals. There are 8 distinct periods of data collection, with each period being 2 weeks long. We are currently in the final week of data collection. The steering group came up with 8 key performance measures covering pre-op, operative, and 30-day outcomes. Our pre-planned methodology was to do a scoping phase. So as we learn what is important from the data that comes in real time, with the help of the steering group, we will identify the priority focus for the first manuscript. Next slide, please. These 8 measures span the care journey of a patient from symptom onset to when they are seen by the surgical team, surgical intervention, and post-op care. This allows us to benchmark care delivery and identify breakdowns in timely access and infrastructure. Next slide, please. So here are some preliminary highlights. We have collected data from over 29,000 patients from 1,200 hospitals across 111 countries so far. There is strong participation from all global regions with good distribution across income settings. Next slide, please. Access to CT scan varies dramatically by income group. Next slide. As expected, minimally invasive surgery remains unequally distributed across income settings. Next slide, please. Interestingly, the last major literature suggested that perforated and non-perforated appendicitis were distinct entities, not related to time. But our early data suggests that there's a correlation with higher perforation rates when patients delay in coming to seek care. Now, this has immediate implications. Next slide, please. As expected, complication rates are proportionally higher in patients with perforated appendicitis. Next slide, please. So there are three key potential messages we are considering for the first manuscript from this work. I'd like to invite you to vote on what you think is most interesting and pragmatically actionable. So option 1 would focus on patient pathways, diagnostics, and perforation. The idea here is that perforation is time dependent and could directly influence global practice everywhere. We propose a new standard. Patient with right iliac fossa pain should be reviewed by the surgical team within 24 hours, similar to how our medical team manage stroke and MIs. This should be treated as time critical. Option 2, the message should be around minimally invasive surgery and how we can support its scale up in low middle income countries to reduce complications and improve outcomes for patients. Option number 3 is that we present all 8 key performance measures, offering a broad system level picture of emergency surgical care worldwide. So if you can kindly just scan the code and just let us know what you think. Thank you very much.
Okay, thank you very much. So we've heard about Alligator, which is the study we've done this year. We just wanted to kind of share some thoughts about what we might do next. So next slide, please. So put your hands up if you were involved in the COVID Surge Week study in 2020. Yeah, so a fair few of you. So those of you who were involved will remember that this was a study in October 2020 when we included every consecutive surgery performed over the course of a week that was selected by the teams taking part. And we collected in total 140,000 patients from 1,674 hospitals. So definitely some limitations still. The hospitals taking part, not fully representative of the whole world. Still struggling sometimes to get through to some of the rural centers, particularly in the non-English speaking countries. But you know, it was at that time the largest study performed in surgery prospectively, and we even won a Guinness Book of Records certificate for the most authors on a study. So there were 15,000 people on that study. So when you hear that the physicists hold the record, that just, sorry, that's no longer true. But this study was really important because it actually provided the definitive evidence base for how long we should wait from somebody testing positive for SARS-CoV-2 to having surgery. And this was in the pre-vaccine era. And this was really important. It influenced global guidance all around the world. And as far as I'm aware, this recommendation stood the test of time up until things changed with vaccination and changing epidemiology. This study has also provided data for a number of other studies, including several of the modelling studies that have been summarised in the Lancet article that we presented today. So, next slide, please. What we are contemplating, I'm sorry that picture doesn't come across very well on the screen, but it's meant to be the world with a couple of surgeons in front of it. But I'm not sure how clear that is. But it's what we're contemplating is the opportunity to undertake a similar study to Surge Week in mid-2026, so in about a year's time. Clearly, we won't be focusing on COVID at this stage, but what we're thinking is that we could have a core data set that we collect across all types of surgery, so sort of maybe 15 core data points. And then we might have what Anil has called thrust areas, which are where we collect additional tailored data points for specific procedures, specialties, diseases, which perhaps are gaps in the evidence so far. So potential areas for these thrusts could be laparotomy, could be fracture surgery, could be cesarean section, robotics, and I'm sure there will be others that we can think of today. So it was to really start a conversation about what this study could look like, what would be the useful outcomes, the useful data to collect, and we'd be really interested in your thoughts. So I think we'll move to the panel now. So if the panel are happy to join on stage, thank you.
Hello, everyone. My name is Elizabeth Lee. I'm one of the assistant professors and surgical residents from Birmingham, UK. Thank you to the panel who are joining us today. If everyone can please introduce themselves. We'll start with Dimitri.
Well, you've already met me. So my name is Dimitri. I am a public health doctor working with the Global Surgery Unit.
Richard.
Sorry about that. I'm Richard Crawford. I'm the director for the Global Surgery Hub in South Africa.
Hello, Antonio.
And I've changed demographics just to confuse you for tonight.
Hello, Antonio Ramos. I'm the NIHR Global Surgery Unit lead from Mexico.
Good evening, Faustin Hidenganya, Hub Director from Rwanda.
Hello, everyone. Ismail Lawani. I'm the Director of Global Surgery Unite in Benin Republic.
Hello, everyone. So I'm Janet Martin, and I'm from Canada, and my main area is anesthesia as research and implementation in Ontario, Canada. And I also work with the World Health Organization and other agencies around the world in terms of policy and implementation.
Brilliant. Thank you so much. If I may first summarize the take-home points for myself so far, the words over this few days that I've heard a lot is investment and dividends. In other words, upfront costs that you may not see returns from for many years or even potentially decades. But perhaps this is our opportunity to reframe what surgery means. Previously, research was a single intervention or a single operation, but now we need to really start recognizing what each intervention means in the scope of patients' lives. So, for example, one of the examples that was brought up within the Lancet paper was inguinal surgery, so inguinal hernia surgery. It may seem like a single event and the patients go back into the ether. However, chronic pain, inability to work, inability to pay taxes, look after young or elderly is a major issue, and it has societal impacts that perhaps we've not been capturing before. And at the same time, surgery doesn't stand alone. We need excellent anesthesia care and good pathways to ensure that it is efficient, what we deliver, and the infrastructure we set up is able to sustain populational health that can last for years. But it's that upfront investment that we need to get over the hump for. So good data like this and numbers that we could potentially lean on policymakers and their pain points is excellent to be able to move forward and change the optics to a more long-term view. Janet, so talking about pathways and anesthesia, I was wondering if you could expand on how improving referrals, improving the pathway and flow of patients could potentially help improve surgical care.
Well, that's a big, huge question. And so we have a paper upcoming, which I think will be of interest from the Global Surgery Unit, which took a look at inguinal hernia. One has already been published, but the second one is also taking a look specifically at anesthesia and perioperative outcomes. And I'm raising that first because I think this is a really great leap forward in terms of surgery and anesthesia working together towards global data collection across all regions of the world. And we hope to make that a routine partnership where we have surgery and anesthesia data across low resource settings and high resource settings. And so we're going to have these data packages that are available into the future, and I think that's going to give us a lot more insight as to what the differences are in terms of our pathways. And also then marrying that up with our SPY tool, which takes a look at different ways that we can improve our readiness for patient intake. So coming back to your question, how can we improve surgical intake and pathways? It really is a systems issue. I don't have the answer yet, but I do think we could certainly do better if our teamwork was so much better joined up. Because right now we're still struggling, even in my center, to be joined up, surgeons and anesthesiologists, with our patient intake, with our knowledge flow, and with the continuity of that. And I think that really is one of our future areas where we're going to have to close the gap and where we could make a huge impact that hasn't yet been tapped.
Brilliant, thank you. Foster, I'm going to move on to you next. So one aspect that we are always banging a drum about is safety. So high quality surgery whenever we possibly can deliver this. And trying to reduce infections around surgery and also post-operative outcomes. I was wondering if you had any thoughts or comments around safety and how we could potentially reduce consequences of risks.
Yeah, thank you. I was expecting probably that question to Martin. She is an anesthesiologist, and safe, for me, surgery should be safe, and we don't need to add the safe after surgery because it should be integrated. So if we say safe surgery, it means we can do unsafe surgery, and that is not surgery for me. So that being said, I think all what we do is to try to make sure that people don't get sicker because they have been treated. So we have to make sure that safety is at the corner of everything we do. Even when we create pathways, like she was discussing, for me, a pathway is a structured way which is evidence-based to plan for surgery and improve outcomes. And safety should be an integral part of that. And for me, if I come to the beginning of my thought, I would say I prioritize safety. So for me, it's better not to operate when you are not safe.
Yes, thank you. That very, very astute comment. So it is a multifactorial, I understand, and it should be integrated in every single step that we review patients and bring them through the pathway. Luwani, I was wondering if so one aspect that Dimitri had presented was about infrastructure, about how, for example, if a CT scanner was installed within a hospital, it potentially can offer scanning services to the whole hospital, to a community. It can last for a decade. Is this vertical integration something that would potentially help communities?
Yes, thank you. I agree with you. Those kind of facility improve at first safety of surgery because it helps us to make early diagnosis and to perform the right surgery. And but you know, in our countries, due to the limitation of investment of our government, we didn't have access to those kind of facility. So I agree with you that we should improve the availability of those kind of facility. It will help us. Thank you.
So almost once again, an upfront investment that potentially can provide dividends through future identification of illness, potentially avoiding unnecessary surgery, a key aspect of it. We want to try and do no harm, and at the same time, potentially provide services to the wider community and to the hospital population as well. Richard, I'll move on to yourself. So one aspect that Virginia touched upon was AMR, so antimicrobial resistance, antibiotics being the absolute backbone of surgical practice. We rely on this so much. So what is the potential future and what do we not know?
Yeah, I think it's already been mentioned that there's this fear that funding is going to go back to infectious diseases and kind of surgery is going to be left out. In 2022, the Lancet published and pretty much the figures were that 1.27 million people are directly dying from AMRs. An additional just under 5 million people are associated to drug-resistant AMRs. Our group, the GSU, has shown just how important surgical site sepsis is, how it's a significant contributor to morbidity and mortality, and how that's disproportionately larger in low middle income countries. The problem is a lot of the data that we're publishing on antibiotic resistance is specific to hospitals, hospital level. It's not granular enough for us to really make global or national policies around antibiotic usage. And if we don't get on top of this from a surgical society, we are purely just going to contribute to the morbidity and mortality numbers that we are already quoting in this Lancet. And so it really is important that groups now start focusing on getting real world data that covers low and middle income countries that we can look at developing policy.
Interesting, definitely. Well said. Antonio, just coming off that point as well, data. So I think Anil had touched upon this and we have talked about this a lot and it's been mentioned frequently, and Professor Morton as well, that we sometimes don't know what is happening on the ground. So it's difficult to make lobbying claims or lobby policymakers without real world data from the ground. How can we potentially as a community move on from that?
I just don't want to sound like I'm repeating talking points, but we have to be honest. I mean, the world is changing. We need to come up with new ideas. We need to come up with different ways of convincing policymakers. Data is there. We've shown it. We've delivered it. But as has been mentioned before, implementation is something that we need to do. So what we have to do is, get that data implemented. And we pride ourselves in running large pragmatic trials. So we have to be pragmatic on the way that we are going to be doing this. As I was saying, let's be honest. I mean, so far this should be probably called not the World Health Assembly, but the Funding Cuts Assembly, because I mean every session talks about that it's something that it's real, and we need to come up with different ideas. And data alone is not going to make it. We need to bring more people on board and probably creating shared value, what might be important, bringing more people that have vested interest in what we're doing.
Yeah, absolutely. Be a bit more agile, inventive, exploring with where we can potentially find other sources of funding. Totally agree. And then finally, Dimitri. So there's possibly a false economy that is being perceived, the optics of it from perhaps government, from other individual funders, is that surgery is expensive and that it may not have as big of an impact that we have suggested from our paper here. And I'd also add that even other aspects of surgery, such as investing in laparoscopic surgery, could reduce hernia rates postoperatively, surgical site rates postoperatively as well. Lower surgical site infections, again, potentially could reduce hernias. So should we take a more broader scope of the downstream consequences?
Thank you. So I think it's an interesting question. And I think the first thing, as Antonio says, we need to be honest. And the reality is you can't develop surgical services without a significant investment. You know, we would be deluding ourselves if we didn't think that it will require that. So just reflecting on my UK experience, because that's where I work, one of the challenges we often have when considering funding for new programs is that the potential benefits of those programs, financial benefits, sometimes sit in a different funding pot to where the money is being spent. So, for example, the hospital is considering to invest in a particular intervention that will reduce some kind of the need for care home admissions after surgery, let's say. But the difficulty is that the care home is paid for by the social services department at the local government. And so for the NHS, the health service, to invest in that intervention, it doesn't necessarily bring a direct financial benefit to them because the benefit will sit somewhere else. And the converse might be true. Perhaps the public health department considers an intervention that will reduce smoking-related admissions. That doesn't necessarily generate any income for the public health department. It might help reduce costs elsewhere in the system. But the policymakers are generally, you know, unless you're the president or the prime minister, you are only looking after a particular pot of the overall government expenditure. And the benefits outside of that are not particularly that useful to you, perhaps. So what I would advise here is I think we need to be very context specific with how we develop and interpret cost effectiveness models, because what might be cost effective for one health system that is set up in one way may not be the same in another system where perhaps patients bear more of the cost and therefore the hospital investing in a CT scanner doesn't necessarily save the hospital money. So we need to be a lot more stratified in our thinking, I think, and have much more scenarios when we publish papers and allow people to interpret that evidence and interrogate it according to what is meaningful in their context and how they then present it locally. So that's the first point. The second point I would just make, building on the point about prevention, is that there are things we can do that are relatively less expensive. Generally, that means through regulation. So, for example, in the UK, the government was looking for a quick win on its health agenda. And the idea they came up with was bringing in some really tough, probably the toughest in the world, regulation around tobacco to reduce smoking and the impact of smoking on health. And there will be examples of things like that that can be done in different countries that perhaps don't necessarily require a huge amount of spending. AMR, you know, there is a lot that can be done around regulation of how antibiotics are prescribed and distributed, particularly in the community. So it would really be a call for the surgical community, the anesthetic community, to be part of those kinds of wider public health conversations. The cardiologists and the respiratory doctors are often a big part of those conversations. Surgeons very rarely, at least in my experience, contribute to that. And I think there is a really important contribution that could be made, and I think it would be very welcome.
Yeah, well said. Professors Tabiri and Soji, please.
Okay, thank you very much. I'm going to try to answer common question about how to look internally for funding. And I think by answering that question, I'll introduce the team from the Ministry of Health. We invited you, we struggled to get you here because we want to look internally to fund some of the projects that we are doing. For example, we are launching Tiger Study because the communities told us that they need their inguinal hernias to be repaired in the communities before they get complicated. They don't want to travel 300 kilometers to go and get their hernia repaired. So that is why we are here. So I'm going to introduce you, and for that purpose, that is why we are here. So we have Dr. Franco Usu-Sechere, who is a rep of the Ministry of Health from Ghana. And then we got Miss Perpetua Ofori Ampofo, who is also from...
Please stand up. Welcome.
And then we have Dr. Richard Solomon. Solomon is a union leader, General Secretary of Ghana Medical Association. And I think he's also a member of the ENSO Ghana. And we are here telling you that if you want a baseline data, please contact us and we'll help you to collect baseline data.
Excellent, well said.
In Ghana, because we've done it before. And then we've got Laurentia, who is also my student. I didn't know you are coming here. So representing the Minister. Another point I would like to add is that when we talk about global surgery, usually the thinking and what comes to mind is from high-income country to low and middle-income country. But the work we have done shows that we can also show the high-income countries how to do things. For example, from our data on inguinal hernia cohort study, we realized that local anesthesia and regional anesthesia are commonly used in inguinal hernia repair, whilst in the high-income countries, it is a general anesthesia. General anesthesia, gases, environmental issues, with the surgical theater contributing, or surgery contributing to about 0.1% of all environmental degradation. So what it means is that we can also learn from the low and middle income countries how we also do things, and then to help the entire world. Thank you very much.
Thank you very much, Professor Tabiri. I would like to also introduce the Nigerian delegation. I think Stephen has taken much time, so I won't be spending so much time. Leading the delegation is the Director of Health Planning, Research and Statistics in the Federal Ministry of Health, Dr. Camille Shoretire. Thank you for coming. He has been a pillar of support to us locally and many of our programs at the Ministry of Health. Also with him is Dr. Adaize Okonkwo, who is a Deputy Director and Head Health System Strengthening in the Federal Ministry of Health. Dr. Okonkwo, you are very much welcome. And at the subnational level, we have a Commissioner for Health who has joined the team, Dr. Tomi Kuka. You are also very much welcome. They are
they had a speaking engagement. That's why they came late, but they are really very committed to what we are doing. Thank you for coming.
Thank you so much, everyone. In the interest of time, we will move on to make the final words to our esteemed colleague, Professor Ghaffar. And thank you to the panelists.
So thank you, Lizzie, and thank you to both the panels. I think there are a couple of things which have been common in both panels. There are three things which I think has come. One is the budget cuts, and I think there have been a lot of emotion, commotion about the budget cuts, but there are no budget cuts in the high-income institution except your research. In the service delivery, the ODA is the Overseas Development Assistance, and that these are two separate things. So when we say there's going to be, Richard, I have forgotten your last name, if I can take your name. Richard, is it okay if I call Richard? Okay. So this $23 billion is significant amount, but we have to remember there are a lot of reports. I'm not saying there are exceptions, outliers. On average, almost all LMICs only get 3 to 15% ODA as part of their health budget. There are some exceptions. So I think other thing, what is happening in WHO, the people who work for with the WHO, I had the pleasure to work for WHO for 20 years. There's a less than 1% full-time person who works for surgery. And that's also on the WHO headquarters. So whatever happens with WHO, not good for the development. And the second thing, WHO is not a funding agency. It is a technical assistant agency, and it's a standard setting agency. So it will not have any serious repercussion, whatever we want to do into the global surgery. And I think that Catherine mentioned people going to the USAID. USAID does not fund surgery. And I think, John Mira, you said when you said China will fund, no. If they want to fund, they will fund to their National Bank of Reconstruction or something, and that's a very different way they are going to support it. So I think there's nothing to worry. So those are three things. I just want to see it. If you understand the ODAs, there's not one country in the world who gets the ODA to invest into the tertiary care hospitals or the secondary care hospitals. They don't give any money except the World Bank. But that's a reconstruction. That's not a technical assistance. The technical assistance for all bilaterals and WHO is primarily for the primary health care. And that's a different challenge. The colleagues from the Ministry of Health are sitting, and I had the pleasure to work for the Ministry of Health for 15 years. There are serious issues for the domestic financing. There are competing priorities. And one thing we should remember, if something is working in these countries, these are tertiary and secondary care systems. And within the tertiary care and the secondary care hospital, if something is working, it's the surgery. Government still gives a lot of money, workforce investment to have reasonable, like very good quality, but reasonable access and affordability. The challenge is, we mentioned there's out-of-pocket expenditures, and that's another issue, which is a healthcare financing issues. And then the things needed are like health insurance and other things, which we need to see this all. There WHO can help the country that what sort of healthcare financing strategies and function we can have it. I think the challenge for us is, my friend and colleague Dhruv was saying, in many countries, especially in Asia, nurses are completely undermined and ignored as part of their healthcare workers. In Africa, it's very different. So there's a context, there's a diversity, and then there's a recognition and respect. And that is where I think the surgical groups can come and they can ensure
How can we have a respectful workplace where it's not only surgery? I think out of the 5 recommendations, Dimitri said there were 2 about integrated, stronger health system. The challenge is, when I was in the medical school, it's a long time ago, professor of surgery was like a god and they behaved like a god. And I think they're still reasonably good gods. And that is where I think we need to work. There's a prevailing mindset, not only in the low and middle income countries, but also in the high income countries. People need to move to the next office, have a coffee, discuss with the teams who are working and investing into the healthcare system and healthcare financing. And I think the surgeons are in a very good position because in every country, every president and prime minister has a personal physician. And they are bright surgeons, not the primary healthcare physicians, not the primary care health. So you have access to the power corridor. Surgeons are obviously one of the brightest lot within the health community. And you have to prove that you are bright. You can strengthen the health system, not doing the good surgery and excellent surgery. So I think those are my reflection. I'm sorry, I'm not a surgeon, I'm a physician. But so I can say what I have been doing for the last 35 years. I have been planning, developing, managing, evaluating, monitoring health systems and working with the policymakers. But I think the opportunity is there. We can use the word integrated, we can use the word implementation, but I still think there's not enough knowledge that how can we go and negotiate and talk to the policymakers. If you want to invest in surgery, this is how it is going to strengthen your health system and the broader health outcome. If you don't invest, this is what you are going to lose it. And I think that narrative has to come. Thank you very much. Very kind.
Thank you very much. I think it's essential as we round off to take a few points home. One of the things we've learned from the Lancet policy is that surgery is not a luxury, but it's an essential right, both to health dignity and a promise of universal health coverage. Though it's under prioritized and underfunded, it's seen as complex and expensive. But the truth is that it is key to strengthening health system. We also noticed from the work that no LMIC has achieved any of the targets. But there is a silver lining that we could actually get over 80 billion return on investment if we can scale up cancer management. And I think one of the things we should take home is that now we have talked about contracting funding opportunities. The infectious diseases specialists will still look for funding. We need to be at the table this time. We should not allow them to run ahead of us. And I think that's quite essential. So this leaves me to really thank everyone for coming, all our panelists, all our session chairs, and everyone. I hope it's been a 2-hour well spent. Thank you very much.